So we'll start with ALK inhibitors. The way I think about this as we go from first to second to third generation inhibitors, it's really these drugs, as you go from first to second to third, you see increased potency against ALK, increased CNS penetrance, and then coverage of ALK resistance mutations. I'll tell you a little bit about the fourth generation agent, which again is a little unique in that it has more coverage of ALK resistance mutations. So, over the years, we've seen, big questions in this field is how do you actually sequence agents? Do you go first, second to third? I'll skip that just for the sake of time. The answer is no, absolutely not. We should not be using crizotinib anymore. I think over the last couple of years, there's been a question of, the strategy of do you start with a second generation inhibitor such as alectinib, brigatinib, and then go to a third generation inhibitor like lorlatinib, or do you go straight to the third generation inhibitor? I think the answer is pretty clear now, but I'd like to walk through that data. This slide is boiling a lot of data in one table, but essentially what I'm trying to do here is summarize all of the different clinical trials where we're taking second generation drugs and comparing it against crizotinib. And pretty consistently what we see is overwhelming benefit with starting with second generation ALK inhibitors. And if we look at median PFS by blinded independent review, we're seeing around 26 months, but high response rates, high intracranial responses. And for some of these agents, like alectinib, we've also seen improvements in overall survival. You can see here data that Solange Peters recently published on the right from the global ALEX study. There is an improvement in overall survival. I would add a caveat here, though, that in the ALEX study, there was no crossover. And so, if you look at a very similar study, the J-ALEX study that was done in Japan that did have crossover, there was no survival benefit in that study. Survival benefit here really speaking to, the power of crossover. So in my view, lack of an overall survival benefit as we start getting into some of these studies is not a deal breaker. Of course, when we use, ALK inhibitors like alectinib, brigatinib, when we see a median PFS around 2.5 years, what causes resistance? And I'm not going to get too in the weeds here, but broadly speaking, we think of three major types. We think of on-target resistance, that is new mutations within the target kinase itself. We think of bypass signaling pathways, that is other receptors that get activated that reconstitute the signal downstream. And then lastly, and I would say this is quite rare, but then we see lineage transformation, that is moving from a non-small cell to a small cell lung cancer. In contrast to EGFR, where that's 10, 15%, in ALK this is quite rare. It's 1 to 2% of the time. So, when you use these second generation inhibitors, what do we see? So this is now an old paper that we put together looking at ALK resistance mutations, and we see a smattering of different ALK resistance mutations. The main take home on this slide is that with a second generation inhibitor, about 50% of the time you see an ALK resistance mutation at progression, and they tend to concentrate in this G1202R residue that labeled there in red, and it's a vulnerability of all of the second generation inhibitors. What can you do when you see that? So one can use the third generation inhibitor, lorlatinib, there. But what we've learned is that when you try using the third generation inhibitor in that context, whether you have one of those ALK resistance mutations or not really matters. Is your tumor still dependent on ALK? I mentioned dependency, not because these tumors still retain the fusion. It's just a matter of whether there's a bypass pathway or not. If you have an ALK resistance mutation and then you use lorlatinib, the response rate's quite high. It's 70%. If you don't, though, the response rate's much lower. It's closer to 30%. And that could just reflect some tumor heterogeneity. And so this idea of trying to maintain your options and sequence, doesn't really give you much length when it comes to using lorlatinib in the second-line setting. And the problem is that what we see is that you start developing these compound mutations. If you start with just one resistance mutation and you give lorlatinib, what you end up seeing is you see this emergence of more and more mutations on top of that, and then that gets really challenging to treat. That's the idea behind neladalkib. This was actually presented, an update by Jessica Lin from my group earlier today. And, I think where this agent is positioning itself is really, I would say in some of that older paradigm of starting with second followed by third generation TKIs. And this drug is certainly active. And where its place is right now, it's able to overcome some of these resistance mutations, including those compound mutations. So that's like the strategy of second to third, and then you could add the fourth in that middle box. But what about just starting with lorlatinib? I think we've seen a series of updates over the years with the CROWN study, but just as a reminder, this took newly diagnosed ALK-positive lung cancer patients, and they were randomized to either lorlatinib or crizotinib. And when this study started, there was still use of crizotinib globally. We've seen a couple years ago now, Ben Solomon presented the 5-year update, and we saw a marked separation of curves here. Right, and this was striking because at the 5-year mark, the median still had not been reached. Right, so I think for most people, I was sold on the 3-year data. I think most people, were sold when they saw the 5-year data. Now, if we fast forward, this is just meant to show at the 5-year mark. Just I know cross-trial comparisons are always fraught with error, but I think this is an example of where just even with the 5-year data, there was a pretty marked difference between the CROWN data and the data with alectinib and brigatinib. What of course differentiates this agent though is it does have a unique toxicity profile, and what are some of the AEs that really differentiate it? I think the cholesterol elevations, that tends to be an early adverse event that requires careful monitoring. And then it's really these neurocognitive effects. And these can take various manifestations, so including things like mood symptoms, things like irritability, we can also see cognitive changes. There's really a broad spectrum. So it really requires careful discussions with the patient and their caretakers, because these are quite common. Importantly, they do respond to dose reductions, dose interruptions. What we saw just 2 days ago now, I think, Tony Mock presented the 7-year update, and I think what is particularly striking here is that between year 5 and year 7, there was only a decrease of 5% in terms of the PFS rate. So this is really striking that we're now at 7 years of follow-up, right? And the median PFS has still not been reached. So I think if you're going to take home 1 point from everything I've said so far, is I think that this really means that lorlatinib is the new standard of care for first-line treated patients. Because if this plays out, this could translate to a median PFS of like 9 years, which is really unprecedented.